morning, everyone. This is Marisa D'Angeli with the Washington State Department of Health. Thank you for joining Equip for Long-Term Care. We have a great presentation planned today on implementing stewardship in a rural nursing home. But before we get started on today's program, I wanted to mention a few things. First of all, I did send out the slides for this presentation on Monday. I do get a lot of bounce backs. And that could mean either that those people have no longer work at that email address, but if you've never received an email from me, it means that your email is incorrect in the system. So I just wanted to alert you to that. And second thing is the recordings of our prior Equip webinars are now available on the Equip website. So if you missed any of them, you can go there and listen in, and you can also recommend them to your friends. So the other things I wanted to mention are, please mute your phone if you're not speaking. Don't put your phone on hold, and use the chat box to answer questions during and after the presentation. I've mentioned the opportunity to participate in an Equip for Long-Term Care small group collaborative, and so far we have a small group of skilled nursing facilities, and we'll be getting started next month. So for those of you who have enrolled in Washington, you should have received a welcome email last week. And if any other nursing facilities want to participate, please contact me. And finally, I wanted to remind you that the Leadership Commitment Poster is available. You can actually download it and customize it yourself. It's accessible from our website. Or we can print it for you, customize it and print it for you. And for the people who did order them, you should have already received yours. So please let me know if you didn't receive them. And now we'll be moving into our presentation for today. I wanted to introduce our speaker. Dr. Joseph Boero is a certified medical director of the American Medical Directors Association and is currently the medical director for the Park Manor Nursing Home in Park Falls, Wisconsin. He is retired after 35 years of practice in primary care in internal medicine. He's also a board member of the Wisconsin Association of Medical Directors and is an active member of the Wisconsin Coalition for Healthcare-Associated Infection and Long-Term Care. So he has on-the-ground experience of leading stewardship in a rural nursing home, which I think will be very valuable to hear about with our group. And he came highly recommended from my contacts at U.S. Centers for Disease Control and Prevention. So I'm really looking forward to hearing his talk today. And the last thing I wanted to say was just that Dr. Boero has inserted some questions into his presentation, and we ask that you use the chat box to answer those questions, and we'll be tallying up the results and talking about them at the end. So I'm going to turn it over to Dr. Boero.
Okay, next slide, please. I'm sorry for the delay in getting connected. I've never done one of these webcasts before, and I'm hesitant to do it because I can't see your face, and I don't know if I'm connecting with you, and I'm not getting energy from my audience. So we'll try anyway. I didn't post any learning objectives because this is a case study. My only objective in speaking to you is that you'll be able to hear and understand what I'm saying about what we did in our nursing home in northern Wisconsin, and perhaps appreciate what we did to the point that you all may cultivate the audacious thought that you might be able to change the practice of medicine in your buildings. Next slide, please. We're in right near the Red Star, the top center of Wisconsin. We're about 40 miles from Lake Michigan in the middle, or Lake Superior in the middle of the Chequamegon National Forest. We're at a community of about 2,800 people in a county of about 11,000 people. We have 90 skilled beds. We are one of 2 nursing homes in the county. We're in the northern part of the county. Southern part of the county, there's a 35-bed facility. We have a CNA school. We do 2 cohorts per year. We're lucky enough to have a CLIA certified moderate complexity lab, so we can do most of our own lab. We're a private for-profit facility, and we are owned by our employees. Our community had, that's okay.
Sorry.
Our community, that's right. Our community has a local hospital with an attached clinic for primary care. Our tertiary referral is a 90-mile ambulance ride to the south. And what you have in front of you is our administrative team. On the left is our infection control nurse, Karen. Lady in the white hair is Paula Cook. She's our DON. She's a fine person to go to a meeting with because I can always find her. I've known her since 1992, and that's her real hair color, I think. Next is Debbie Klatkovich, the administrator. I'm the tall, skinny guy, and we're all giving each other flu vaccine shots 2 years ago. I'm giving our chief financial officer, Sharon, a shot. Next slide, please. Our adventure in infection in antibiotic stewardship started about 11 years ago. In July of 2006, I was in the conference room of the nursing home, and on that day we had 10 MRSA associated skin infections in our staff. Our clinical line nurses, CNAs, and 2 janitors had skin sores, while in our residents, we had 9 of our 89 residents receiving IV vancomycin for a staff outbreak in our building. And we thought we were at infectious disease Agamemnon. We had just come off of our first recognized modern day norovirus outbreak at the middle of June. That finished, we had about 70 cases in the building among employees and staff. And next slide, please. And we're chewing this over. What were we going to do? And having our meeting in our conference room there, so I punted to the audience around me because the audience always knows the right answer. And can we have the next slide, please? And one of my revelations along the way is, if there's no problem in any nursing home that the people who work in the nursing home can't solve, because the people who work in the nursing home are the experts, in my opinion. It's not the surveyor system, it's not the academicians, it's the people who are doing this every day. And my audience said, the problem is we have a lot of antibiotic resistance, it's the damn doctors, they treat everything. And they looked at me and said, you're the medical director, you got to tell them to stop. And I thought, okay, how can I tell my colleagues that they're doing something wrong, leading to what we're seeing in our building today? And I said, the most intelligent thing I've ever said in antibiotic stewardship is, get me some data. Next slide, please. I said, I can't go to these guys and tell them to do something if I don't understand what they're doing themselves, if I can't show them what they're doing and how that's impacting the scope of bugs that we have in our building. So I said, you got to start counting stuff. And they said, what should we count? And I said, well, you have to count everything. We have to count everything that has to do with antibiotics. We want to know what the sensitivity pattern in our building is. We're going to make an antibiogram. And I want to know where the antibiotics are being prescribed, who's prescribing them, what resident is getting them, what wing the infection is on, what are the clinical symptoms, what are the antibiotic doses, what are the culture results, what are the sensitivity patterns. And let's go to the next slide, please. An antibiogram is something that at that time I was familiar with. Before I went to medical school, I was a medical technologist working in hospital laboratories. In fact, I worked in the hospital laboratory of Bonner General Hospital in the Idaho Panhandle. I lived there for 2 years. I met my wife there. It was there that I had the inclination to become a physician. By going back to medical school, I moved back to the Midwest where there's more medical schools, and we got married, and then 40 years later I'm talking back at you and hope someday to get out there and meet you all in person. This is our first antibiogram. Can you go to the next slide? I've magnified the first part of it so you can read this. And if you've not seen an antibiogram, it's a list of organisms and the sensitivity rate of the organisms to the antibiotics that are commonly used. And I want you to look down the first column where it says 27 E. coli. In 2006, when we had MRSA all over the building, including our own hands, we isolated 27 E. coli. If you scan your eyes to the right, 63% of the time the E. coli was sensitive to ampicillin, 97% to cefazolin or Kefsol, and we get to ciprofloxacin, it was 17% sensitive. Guess what the most common antibiotic we prescribed in 2006 was? If you guessed ciprofloxacin, you'd be correct, and then the second most frequently prescribed antibiotic was levofloxacin. And that struck me. But what struck me more was if you go back to the 27 in the first column and scan down to the 29 where it says group D Enterococcus, we had 29 Enterococcus isolated that year. And by this time, I had seen hundreds of antibiograms. I had never seen one where the number of Enterococcus in an antibiogram exceeded the number of E. coli. This was the first. And the second thing that grabbed me was if you scan down again in the number line, 14 Klebsiella and 14 Proteus. I've never seen an antibiogram where the combined Proteus and Klebsiella organisms exceeded the E. coli. In every other antibiogram I've ever seen, E. coli is number one. Klebsiella and Proteus each are somewhere around 7 to 10% of the total organisms, and Enterococcus is somewhere between 4 and 7%. So let's go to the next slide. My staff was right. They my staff was right. I said, you were right. We have a lot of antibiotics. That's okay. We have a lot of antibiotic resistance. Next slide, please. What's more, Karen also counted multiple other things. In 2006, our facility had a Windows XP operating system, which contained a fairly primitive Excel spreadsheet. And she knew how to enter data in columns, but nobody in the facility knew how to sort and analyze data. And so we were trying to look at a large database on a single computer screen by scanning up and down and left and right on this very, very large spreadsheet. And so what Karen did is she printed the entire spreadsheet out and taped it all together. And she got a big box of multiple colored magic markers and color-coded every physician, every antibiotic, every bug, every infection. And I took this picture 10 years later. This is our original spreadsheet of the data she collected. But when it was new, the colors were very bright, and I coined this our rainbow spreadsheet. And when you look at this, when I looked at this, what I saw was on the far left column a very long list of residents who received antibiotics in our building in the year 2006, going back 6 months and then forward 6 months from July. And then across the sheet are incidences of infection treated with antibiotic on that same resident, on that same line. And some of these residents, if you scan all the way over to the right, some of those residents had antibiotic multiple times during the year. And I think the most frequent antibiotic use was one resident that had 11 courses of antibiotic. And if you look at the bugs, the bacteria that are isolated, as the year progresses from left to right, what you see is the first bug, the first organism in the urine usually is E. coli. Second time it would usually be E. coli. Third time it would be Proteus or Klebsiella, and then maybe another Proteus or Klebsiella or two, and then finally Enterococcus. And when you look at this thing and see all these Enterococcus and these highly resistant proteases and Klebsiellas as you scan from left to right. You understand, you see before your eyes what is happening when antibiotics are used improperly in your building. Next slide, please. So I said, this is great. We have an antibiotic, an antibiogram, and we have a a spreadsheet that shows us what our doctors are doing in our building. I can show them. Let's invite them for lunch. Let's invite the doctors for lunch over here. We'll get some sandwiches and some pop and some chips, and we'll show this, and they'll be able to see what they're doing, and they'll be able to change what their practices. And our administrator agreed. She brought the sandwiches. She got the they got the pop and the chips, and we set it all out, and we set the date, notified them, and they came. No, they didn't come. Nobody showed up. We had this exciting information, and not one physician showed up. Surprise. So I knew the office manager at the clinic in town at that time, and I called her and I said, Kathy, we have this problem at the nursing home. We've been working on a project. I need to show our doctors some data. We collected this data, and we asked them for lunch. She said, why don't you come over here? I'll set up lunch and you come over here. I said, okay, when do you want me to come? I said, I'll be there next week. So she set up a lunch. The clinic at that time had about 9 primary care providers in our county, and they have about 60 employees, and they turned it into a potluck. And I walked into their place, their conference room, their dining room there, where they take their breaks, and there was food all over the place. It smelled like shaky pizza on potluck day, and but there were no doctors. But gradually, one by one, the physicians came in, and I pushed some of the food away, and I laid out that rainbow spreadsheet, and I showed them. And I was talking to them about it, and they were looking at it, and I could distinctly remember seeing this physician, Dr. Ahmed. He was looking at it, and he was chewing. I was on the side, and he was chewing the sandwich. He had a pop in one hand and a sub sandwich in the other, and he was chewing, and he looked, and all of a sudden he stopped chewing, and his eyebrows went out, and he said, oh, and he saw what was happening. And I said, and by the way, look at this antibiogram. Look at the sensitivity percentage for the fluoroquinolones which we're using. And that was the first time that we ever gave any feedback to our physician providers. And that was in 2006. Shortly after that, this article from Infectious Disease Society of America, published in Hospital Epidemiology, Hospital Microbiology and Hospital Epidemiology, guidelines for antibiotic stewardship programs for hospitals. And they said the 2 core strategies for antibiotic stewardship is audit antibiotic use. In other words, look at your rainbow spreadsheet on how you're using antibiotics, and then give direct interaction and feedback to the physicians. That's one. The other one is formulary restriction and prior authorization of the fancy antibiotics. That ain't going to happen in my nursing home because we don't own the pharmacy, we don't own the drugs, and the doctors write the orders. We have to do those orders. But we have compromised and not attempted formulary restriction. We're happy if we can get the right drug for the right diagnosis, at the right dose, for the right length of time. Next, please. So next please. I'm going to skip some of these because I got too many slides for 50 minutes. So along comes CDC to help us, publishing core elements in antibiotic stewardship for nursing homes in September 2015. Next slide, please. And the clock striking for us in nursing homes on November 28th this year, in which phase 2 of the mega rule change takes place, and we're bound on that day to be able to show the surveyor when they come in our building that we have antibiotic stewardship program, and we have to get ready for that in spite of the fact that guidance to surveyors has not been published yet. The S&C letter telling the surveyors how to assess a facility hasn't been published. So it will be a surprise. However, if you look at these core elements, these 7 core elements published by CDC, I will predict that if you look at what I have highlighted in red here and printed larger so you can read, if you do these 3 things, you can claim to have a legitimate antibiotic stewardship. You have to have at least one policy or practice in your facility to improve antibiotic use, and you have to have one process measure and one outcome measure, and then talk to your providers and give them feedback on how you're doing. Next slide, please. So, for example, an antibiotic stewardship policy is a facility's statement of mission to monitor, intervene, and improve the chain of events or processes leading to antibiotic use or bacterial infection. A process measure is something within the process you can count. I'm going to give you an example of that. And an outcome measure is something you can count after you intervene in your process or your system to make an improvement in antibiotic use. Next slide, please. So, for example, a policy, for example, might be, it's a policy of our facility to improve the use of antibiotics in urinary tract infection by decreasing the inappropriate use of antibiotic. And we're going to consider an inappropriate use of antibiotic in someone who is being treated for asymptomatic bacteriuria. That's a policy. Okay. Now, process measures, you might look at the number of urine analysis done in your building per 1,000 resident days, or you could look at number of antibiotics prescribed for residents with urinary tract infection per 1,000 days. And an outcome measure might be when you count the number of urinalysis which are done appropriately according to your facility best practice definition of what is a symptomatic UTI. Or you might be able to count an outcome measure of when a resident's, the outcome measure of how many antibiotics per 1,000 days are written when a resident's clinical symptoms meet facility best practice definition of appropriate antibiotic use. Or you might be able to have an outcome measure as when antibiotics are dosed appropriately for renal function when you have your pharmacist on board helping you do that. Next slide, please. So we were counting urines starting in 2006, but, mainly because we didn't know what else to do. And we showed that in 2006, we had 289 urines done in our building. And that included 202 primary urines and then a repeat urine on the same resident 87 times. And the reason that happened is we had a couple of our physician providers who had old standing order sets that said repeat urine and urine culture 3 days after last antibiotic. They were testing urine for proof of cure back in 2006 in our building. And that was one of the drivers of our crazy antibiotic use in those days. And so we kind of recognize that because 10 years ago is when people started talking about the significance of asymptomatic bacteriuria in nursing home patients, and it's not necessary to treat them. So we started talking to our physicians about maybe not doing that. And gradually over time, our urine total and our urines measured in urines per 1,000 days or urines per unique resident, that last column, it went down until we got to 2012. And the significant event in 2012 was the publication of Namali Stone's revised McGeer criteria. Old McGeer criteria was based on expert opinion. Revised McGeer criteria is based on literature review. It's evidence-based. And we decided to adopt McGeer's surveillance criteria for symptomatic urinary tract infection as our facility best practice definition. And we decided to train our nurses to evaluate a resident's change of condition when they might have a urinary tract infection based on McGeer's criteria for urinary tract infection and not request urines unless they met those criteria. Next slide, please. We did that at our meeting. Next slide, please. We just were figuring out how to do this, and I'm showing you pictures of Megeer's criteria, but let's go 2 more slides because you already know that. And this is what happened. In 2013, the first year after we did that, our urines went down almost 30%. We went from 167 urines in the building to 116 urines. And if you don't know this, urine testing drives antibiotics orders in the nursing home. And by decreasing inappropriate urines, we were going to decrease inappropriate antibiotics. And now is where I want you to pay attention. Everybody wake up. You see the orange box up there, dialog 1 box. I have to uncover it. It says facility urinalysis metric, question mark. I want you to show the chat box. You do that by pushing on the red arrow, and I want you to type into the chat box. You have to index the cursor and put it in that spot there. If your facility has a urinalysis metric, type yes. If you don't have a urinalysis metric, you don't have to put anything. And also, if you're not shy, put your facility's name and just say urinalysis metric, urines per 1,000 days, or urines per resident, or however you do that. And what I'm trying to do here is get an idea of how far along you are out there in the Northwest in antibiotic stewardship, because someday I'm going to, if I'm lucky, I'll get out there and talk to you in person and be able to gauge on where you are now compared to down the road here. So back to the slide while you're doing that. Oh, by the way, if you have time at the end, Marissa's going to have somebody count these answers up, and maybe we'll try to give you some feedback so you can know how you're doing compared to your peers who are signed in with us today. Next slide, please. So we decreased our urines, and so we looked at our antibiotic use. In 2006, we had 500 antibiotics total written, or antibiotic orders written. That came out to 11.75 antibiotics per 1,000 days, or 2.57 antibiotics per unique residence. And as we tried to decrease urine testing by getting rid of test of cure urine cultures, we came to 2015, 2012. We applied Megeer's criteria, and our urines went down 35%, but our antibiotics went up. In 2013, we had more antibiotics used in spite of decreasing urine testing, and that disturbed me greatly. Next slide, please. And I said that in our next meeting, how come that is? Next slide, please. And they knew. They said it's because we treat too much. Next slide, please. We treat too much, too many coughs. Next slide. Yeah, we treat too many coughs. So when we looked at our rainbow spreadsheet, seeing where antibiotics were used, in 2013 was the first time that antibiotic use for respiratory infections exceeded antibiotic use for urinary tract infections. And I said at our meeting, I said, if we could do for respiratory infection what we did for urinary tract infection, we can decrease our antibiotic use next year by 100 antibiotic orders. And I said that without any regret. I thought we could do it. Let's go to the next one. So we started a QAPI. I coined the QAPI Finding Pneumo, Improving Antibiotic Use in Respiratory Infection, and our goal was to get rid of antibiotic use, which was inappropriately used for viral URI and influenza. Next slide, please. And our QAPI was predicated on the concept, in our building at least, and probably in many of yours, antibiotic orders most of the time do not get written until a nurse contacts the provider and delivers a change in resident condition report. And we thought that if we could get our nurses to do a very thorough and standardized resident assessment with the new cough, and train our nurse to follow a scripted communication to the physician, telling him or her what the nurse is seeing with a recommendation, we could impact the use of antibiotics in our building for viral infection. Next slide. The next slide here. This is the letter, the note that Paula Cook, our DON, wrote. This was included in the pay envelope the second week of January in 2014, and she said, as we continue to improve our infection control antibiotic stewardship programs, we will take the next step, introducing our surveillance tool. It's called McGears. We had not mentioned McGears criteria to the staff until this time. And then Paula said, this surveillance criteria from McGears for respiratory infection is our facility standard of practice. We're starting our initiative in respiratory illness. That's where we used most antibiotics last year, and we were looking at antibiotic use that was probably not necessary. In addition, we have loaded McGears criteria in ECS. Our computer system in our building is an ECS computer system. Quite a few people in Wisconsin use that. I don't know if you have it out there. I am told that there is a PageMaker function in ECS. Paula has some experience in that. She put McGears surveillance criteria for respiratory infection in a point-and-click page for the nurse to fill out, and she uses that to focus her examination, and also to we were hoping that we could guarantee documentation so we could review what they were doing. I am told point-click care has the same ability, by the way, if you have point-click care out there. Next page. So here's McGears. McGears criteria for respiratory illness, I think, is simpler than it is for UTI. It's very simple. McGears has McGears A, B, C, D. A is common cold or pharyngitis. That's viral. Most people say you shouldn't give antibiotic for when your resident has these symptoms. Next. McGears B is influenza-like illness. Most people say antibiotics should not be given. That does not include antiviral like Tamiflu. We are not looking at Tamiflu use here. We're focusing on antibiotics that are used against bacteria. Next slide, please. McGears C for respiratory illness is pneumonia. You got to have all three, including a positive chest X-ray plus clinical findings, at least one of either new or increased cough, increased sputum, change in O2 saturation, and a new or changed lung exam. See that asterisk? I'm coming back to that, because new or changed lung exam means when examined by a nurse, and the next one is pleuritic pain. And then the constitutional symptoms, you have to have at least one of these four. Fever defined as temperature of 100 Fahrenheit or 2 over baseline, or there's a few other things about fever, like I think it's 99.5 rectal or repeated temperature 99 or over. Leukocytosis is a criteria with a white count over 14,000 and or bands over 6,000. And then change in mental status and 3-point increase in ADL, those are the same definitions as used in MDS. And McGears added those as a criteria next. And now, next one, please. McGears D is lower respiratory infection. You have to have all three. It's exactly the same as pneumonia, except you don't have a chest X-ray or a negative chest, or you can have a negative chest X-ray, but still has that asterisked new or changed lung exam. And what they said, next page, please. What they said in McGears, they referenced an article. It is published in Journal of Family Practice 11 years previously. And what these people did in this study, they went to an emergency room in a nursing home, and they trained nurses in how to listen to lung sounds, and they checked for presence of crackles and absence of wheezes, and asked the nurse to document what she saw or what she heard through the stethoscope. Was there crackles or rails and no wheezes? And then they correlated the nurse's finding with the result of the chest X-ray of that patient, and the correlation between an infiltrate on chest X-ray indicating pneumonia and the nurse's ability to hear rails was 0.9, which means that 90% of the time the nurse can find a physical finding that indicates the patient has pneumonia or a lower respiratory tract infection. And the Megeers team gave us that. In fact, if you look at all of the clinical criteria for any of the infections in Megeers Revised, all of those criteria are within the scope of the practice of an RN. Next page. So we did staff development in starting in about the end of January, first couple weeks of February. We did an in-service. I did an in-service. It was recorded. Anybody who couldn't be there had to see it, had to watch it on record. We talked about the facility evidence-based respiratory tract infection best practice criteria. I went through the Megeers A, B, C, and D. We talked about clinical skills. I gave them a short cram course on how to listen to lung sounds. Paula, the DON, found, by God, a YouTube that has lung sounds, and required all of our RNs to listen to that YouTube recording. And they do it every year. They look at either the original in-service that I taped for them in January of 2014, or I revise it and give that at least once a year. We talked about scripting communication. We wrote scripts for Megeers A, B, C, and D, and I'm going to show you an example of one of them, as opposed to being timid on the phone talking to a physician and hoping that that doctor gives you what you want. We're going to be very directive in our communication at this time when we're talking about respiratory infection. I talked about antibiotic stewardship principles. I tried to give them motivational. I try to give them a motivational presentation to get them to believe in themselves, and I validate their nursing knowledge and skill. And we talk about diplomacy and communication. I said, look, ladies and gentlemen, you're going to be talking to doctors and asking them to do stuff, and then they're going to come back at you. And I want you to know that if you're correct, if your assessment is accurate, your documentation is appropriate, our administrative team and your medical director will support you. And in fact, if you have physicians that are giving you some static on the phone when you're trying to do your job, I want you to let me know. Let's go to the next one. Next slide, please. Yes. So this is a sample script for Megeers A. We base these on the SBAR form. SBAR form is a beautiful document. It has everything you need, but I'll tell you, I'll be honest with you, I don't like it because it's 2 pages long. It's very complicated, and as a physician, when those started coming out, I did not read them because I didn't have time to read them. We condensed it. All of the important bullets in the SBAR are here. I'll focus on the last paragraph here, which is the R, which is the recommendation or resolution or whatever you want to consider the R in SBAR. It says, this is to inform you of a changing condition. According to our facility best practice evidence-based policy on respiratory tract infection, this resident has symptoms consistent with viral URI. May we administer cough suppressant according to standing orders and monitor condition for 48 hours. We will notify you of changing status. I'll tell you, not very many people give antibiotic orders when you talk to them like this. In fact, if I was a physician, I see this on the fax or hear that in the phone, my first thought is, these people know what they're doing. They got a plan. I'm okay with it, and they're going to call me. Let's go to the next one. We had these kind of scripts for A, B, C, and D. So in finding pneumonia, what we decided we were going to count is we're going to use the respiratory tract infection definition of Megeers. We're going to use an antibiotic event order. We're going to count when the order is written by the physician and at least 1 day of therapy is given to a resident. We'll call that an antibiotic. We're going to, the indication of respiratory tract infection will be taken from the doctor's orders because our nurse is going to say, what's this antibiotic for? And he'll say, respiratory infection. We'll include that in this database for finding pneumo. We're going to consider inappropriate antibiotic use if it's used for Megeers A and B, and we'll say antibiotic is appropriate for Megeers C and D, and we're going to count utilization rates and antibiotics per 1,000 days, K days, or unique residents. Next page, please. So this is what happened. I said we got to 2013, we had 352 antibiotics. I said we'll do Finding Pneumo, we'll get rid of 100 antibiotics. We got rid of 140. And I was happy. Dialog box 2. Time to wake up and type in here. Does your facility, so you'll type in the box pound 2, question number 2. Does your facility, if your facility has a antibiotic counting metric, and say what it is, just say pound 2, yes, antibiotic orders, antibiotic starts, antibiotic dose per day, or days of therapy, or whatever it is. And tell me if your facility counts antibiotics. Next page, please. Okay, so antibiotics for respiratory infection in 2013 hit a high of 157 for the first year of Finding Pneumo. It went down to 72. Next year, 64. Next year, up a little bit, 79. You know, that per 1,000 days, the antibiotic metric varies a little bit because of our number of days goes down. When I look at antibiotic use per unique residence, it consistently went down. And that all makes me happy too. And this is a sustained, it's a sustained effect. Dialog 3, please do another, say pound 3. I want to know if your facility has best practice definitions for, or surveillance definitions for antibiotic use, if you use McGear's or Loeb. So put pound 3 if you use McGear's, pound 3 if you use Loeb, or pound 3 other if you make it up yourself. Okay, while I'm talking here. Let's go to the next question, next slide while they're doing that. Antibiotic use metric. Okay, let's look what happened to your analysis. When 2013, we were down to 111 urines total, no, I guess 116 urines total. And we started Finding Pneumo in 2014. And look what happened to urine testing. We went, in the next 3 years, our urine testing went down over half. And I interpret that to indicate that in 2014, when we started Finding Pneumo, something clicked in our staff, and they jumped in the boat of antibiotic stewardship. And I don't know exactly what it is. I suspect it's the notion that was given in the original Finding Pneumo in-service, where we talked about stewardship openly, and we talked about facility best practice criteria openly, and we talked about scripting openly. I called Paula this morning. I said, Paula, how many urines have we done so far in 2017? And she said, wait a minute. She was at her computer, and I could hear it clicking into her computer, and I'm sure she accessed this rainbow spreadsheet on urine testing, and she said, so far, as of May 31st, 2017, our building has had 16 urines. Okay, what's significant about that, if you follow this literature, you look at any antibiotic stewardship intervention in any nursing home or hospital or outpatient clinic, almost all of the studies show an improvement in antibiotic uses. There are very few of those studies that include a footnote that the antibiotic use was re-examined in 1 year to see if the effect of the intervention is sustained. And there is no paper that I know of that shows that the change in practice when physicians are intervened in an antibiotic stewardship effort, there's no sustained effort after a year. What that means to me is we doctors tend to gravitate back to bad habits, and there's many pressures, as you might imagine, why that happens. Let's go to the next page. Let's go to the next page because we're running out of time. I'm sorry. Next page. Next page. Next page. Next page. I want to show you some feedback that I do to the physicians. Next page. That's our antibiogram physicians. Okay, stop here. This is a report card. We send this to the doctors. We started in 2013 on treatment of urinary tract infection. The doctors are in the first column. Dr. Dan treated prescribed antibiotics for UTI 42 times. It was appropriate 36% of the 36 times, not appropriate 6 times, not appropriate asterisk. The asterisk says the resident's clinical symptoms did not meet McGuire's criteria for treatment of UTI. As a building, we gave antibiotics inappropriately or out of convention of our facility best practice definition 14% of the time. Next one, please. Every doctor gets this one too. This is respiratory tract infection. Dr. Dan in 2014 treated cough 38% of the time, 38 times, 36 times it was appropriate. Not appropriate asterisks. Residents' clinical symptoms met McGuire's surveillance criteria for diagnosis of viral respiratory infections. We give that to all of our attendings. Last year, for the first time in the urinary tract antibiotic report card, we included a new provider, which is the emergency room of our local hospital in town. Flamingo Hospital ER had 100% inappropriate antibiotic use. Next page, please. That's another talk. Next page. Next page. Okay, feedback. My opinion is that the best dollar spent in feedback is to feedback your nurses. Do the annual in-services. We do that. We hold their feet to the fire to make sure their nurse assessment skills are up to date. They're doing good examinations and they're organized before they call the physician. We do that. Our nursing staff, nursing managers do that daily. I also give the staff the annual state of affairs of infection control, and I tell them how our doctors are doing, and I congratulate them for participating and helping our doctors be better doctors. Next slide. Next slide. This paper, I just put it up there. It's a good paper to, if you're just starting out, it's a good paper to review how you might get going in antibiotic stewardship in your building, because he's focusing on urinary tract infection there, and he says this orange box is what I wanted you to see. Protocols in managing urine testing. He's talking about these protocols should be operationalized not only through education of providers, but also through engagement of nursing staff, who should be empowered to discourage providers from ordering diagnostic urine testing in the absence of specific evidence-based criteria. Next. That evidence-based criteria will be your facility best practice definition of what is a urinary tract infection. I give this talk across the state. Nurse critical thinking, the important component of antibiotic stewardship in long-term care. Next slide. I think the nurses are the key. Here's an article in Annals of Long-Term Care. It's open source. It talks about what the DON can do to cultivate critical thinking. Next slide. Thank you. Next slide, please. Next slide, too. You can read these. When I talk to my nurses, I said, it's not your role to tell a physician how to practice medicine. I tell them, it's your role as a nurse to exercise your discretionary judgment in the application of your skills, knowledge, and experience, and deliver information to the physician to help him practice better. Next. Nurses collaborator. This is why people go to nursing school. Okay, simply stated, almost done. My opinion of what is antibiotic stewardship is, number one, you have to have a good system for gathering data, and you have to gather data consistently. And you have to decide on a best practice criteria for antibiotic use in bacterial infection within your institution. That's your policy. You have to teach your nursing staff how to evaluate and document the steps along the way. That's the process measure. And you have to determine whether antibiotic use for that infection is within institutional appropriate use criteria. That's your outcome measure. You have to give feedback to the prescriber, but to the prescribing physicians, but more importantly, you got to give your nursing staff feedback. Assess, refine, keep assessing. Next, please. And also, in my opinion, a successful antibiotic stewardship program in long-term care depends on that you have nursing staff education, assessment, and communication skills with empowerment to use them. You have to have a consistent data collection and analysis of the data or audit of the data. You have to be able to give feedback to your nurses on resident assessment, documentation and feedback, and physician communication, and you have to give your physicians feedback from your medical director, but more importantly, it's the nurses talking to the doctors and questioning their decisions with it when it's inappropriate. That's how you keep change in practice sustained. Next, please. When November 28th comes along and the surveyors are in our building and they want to know what we're doing for antibiotic stewardship, we're going to show them all these things. This is what we have done. It only took us 10 years. Next. It won't take you that long, I promise. There's a lot of things out there. You can find them on the web. You can find them from your trade associations, from the Council of Nurses, if you have that out there. If Washington has an active chapter of AMDA, Washington Medical Directors Association, if you have one of those out there, they may be able to help you. But I will tell you, none of it's going to work until you start at home. Being confirmed in a culture of administrative and nursing development and empowerment to improve the nursing skills. Good antibiotic stewardship comes from good nursing care, and that nursing care will extend to everything you do in your building. Next. My email address is it's the beginning and the end of this talk. I'm mostly retired. The only job I have right now is I'm still medical director. I have no clinical responsibilities except for my administrative team at my nursing home. So I'll answer emails if you have questions, and I invite them. So I wonder, Marissa, if you can come on. Do we have any counts of these questions that are any meaningful at all?
Hi, yes, we do. So for the UA metric, there were 2 facilities that responded yes. We had, now I see people are dropping off, but we had probably about 50 attendees. Not all of them are nursing homes, but that seems to be a pretty low metric. For antibiotic metric, there were 4 yeses. And for the question number 3 about McGear's versus Loeb, there were 4 facilities that said they use McGear and 0 for Loeb.
Okay.
So it looks like there's some work to do with the metrics.
Or they're shy. Maybe they're shy. And anyway, thank you very much for having me. I had as much fun as I could have in my little office at home while it's thundering outside. I hope to see you all sometime in person. And thanks for signing in.
Thank you so much, Dr. Boero. That was a really accessible talk, and I think probably really inspiring to the facilities, and you are a great speaker. So thank you so very much for talking to us today. I think you probably will be getting some questions.
That's great.
We really appreciate it.
Okay.
And sorry for the technical difficulties.
Okay. Hey, have a nice day. Bye.
Thank you.
You bet.
Okay, everybody, we're going to sign off now. I will take a look at the questions in the chat box and come up with some answers and send them out to you via email. Thank you. Bye-bye.